Good morning. This is a continuation of Theory Part 7. This is Chapter 26. This is Part 3 of a three-part series here. And this is talking, this particular chapter and this session is talking about some other conditions that may be present or develop in the pregnant woman that we will discuss. A lot of this is going to be review for you. So let's get started. So here is, this is from your book, and this is, again, this should be review. You just covered this content in Med-Surg about diabetes. There's type 1, type 2, and then what we call the gestational diabetic, onset of glucose intolerance, first diagnosed during pregnancy. There's type 1A, A1, which is diet controlled, and type 2, which is controlled with insulin and diet, which is not unlike an unpregnant person. Pardon me. So pre-existing diabetes mellitus is often common. Woman is already diabetic and she becomes pregnant or desires to become pregnant. And so the bad things about it, though, diabetes, the presence of diabetes that's already pre-existing can have some maternal effects of makes preeclampsia more a risk. There's more chance of a urinary tract infection because of the increased sugar in the urine, great place for bacteria to grow. If the blood sugar gets too high, we can get into the ketoacidosis state. And then there's also the risk of dystocia related to macrosomia, or a large fetus. And the baby can have some congenital malformations, although it's not quite as common as the macrosomia. Diabetic mothers that are diabetic typically have larger babies. Now that's not a hard and fast rule, obviously, but that's more common. In your neonate, one thing that happens after birth in particular is the hypoglycemia, which is a result of not having that constant sugar coming from the mother. And so they're going to drop their blood sugar. So if we're aware of this, we're going to watch that blood sugar carefully. They're also at risk for hypocalcemia. They're more at risk for hyperbilirubinemia and possibly respiratory distress syndrome. As a matter of fact, I think one week in the NICU, there was quite a large baby back there, born of a diabetic mother, not your usual preterm baby, but the baby that had some respiratory issues and also had problems regulating its temp. Okay, gestational diabetes mellitus, there's risk factors. The woman who's overweight or obese already, she's older than 25 years of age. There was gestational diabetes in a previous pregnancy, a history of an abnormal glucose tolerance level, history of diabetes in a close relative like a mother, grandmother, and certain high-risk ethnic groups, which I meant to look up, but I didn't. So we'll talk about that. Okay. So identifying gestational diabetes mellitus. All pregnant women should be screened regardless of their history. They should be screened. We should look at a history or of some of those risk factors. We might want to do a glucose tolerance challenge test between 24 and 28 weeks. We might do a glucose tolerance test, which is disgusting. You have to drink this awful stuff. And we would do that if the woman is very high risk, or if we think if the glucose challenge test results are elevated. Just a moment. What are you doing? Oh, hush. Had to get onto my cat. Okay, she's doing stuff she shouldn't. So a therapeutic management is just very, very similar to what you learned about in Med-Surg. Sometimes we can control these things with diet. We're going to get somebody in there that really knows about diets. That would probably be your diabetic educator, maybe a dietitian, to help this mother, give her some printed material, maybe give her some meal plans to follow. Rather than just letting her try it on her own, we need to give her some guidance. We want her to exercise if she's been active all along, and she can probably resume her usual level activity, at least in the early stages of her pregnancy. And then she will go from there because exercise, we know, will increase glucose metabolism and lower the need for insulin. We're going to watch her glucose levels either by finger stick or by labs, either the fasting or the 2-hour postprandial. And then, of course, we're going to start fetal surveillance at 28 weeks. That would be your biophysical profile. If you forgot what that is, you need to go review it. We're going to watch that baby very closely. Sometimes women may decide to have an insulin pump, which will help them manage their blood sugars maybe a little more closely. And sometimes insulin requirements may increase, or they may go down depending on the level of activity and so forth, and the level of blood sugar. So again, the monitoring is very, very, very important. So this is from your book, Signs and Symptoms of Maternal Hypoglycemia and Hyperglycemia. And remember from pharmacology, we said hot and dry, sugar high, cold and clammy, need some candy. So that's kind of here too. So be very familiar with this, all right? And so the woman who's diabetic during pregnancy is going to be monitored more closely, obviously. Some women have cardiac disease before their pregnancy, and so obviously this is going to put a strain on any pre-existing heart problems. And so again, the primary goal is to make sure that the heart disease does not progress to full-blown congestive heart failure. So we're gonna do everything that we can to watch for this. We're gonna watch those vital signs. We're gonna watch the weight. We're gonna check the edema. Sometimes we may have this pre-imposed on preeclampsia. So we've got a lot of challenges here as nurses to watch these people and to be vigilant for all of those things. Fluid overload, we may have to do a fluid restriction or salt restriction. Again, it's very individualized, and so most of the time, if they already have some sort of a cardiac disease, they're going to have a cardiologist anyway. So they're going to, between the cardiologist and the obstetrician, healthcare provider, whatever, they should be talking to one another. They should be collaborating on the patient care and making sure that this mother stays healthy. Thereby, the baby will probably be healthy as well. This is not as common probably as some of the things that we've been talking about, like the gestational diabetes or the preeclampsia, but definitely have to be aware of it. So we know that sometimes during pregnancy there is an iron deficiency because it's hard sometimes to meet the needs for increased iron during pregnancy through diet alone. And so oftentimes women will have we'll be taking iron supplements. And don't forget that acidic vitamin C helps the iron dissolve better. So have them take it with orange juice. It will help it dissolve and be more effective. It is constipating, we know, and we also know that it can upset the stomach. So maybe take it with orange juice at breakfast. And then with the constipation, there might need to be some stool softeners or possibly laxatives, increased fluids and fiber, so forth, all the things that we would do. Now remember, just because a woman's hemoglobin is 10 does not necessarily mean she is anemic. You know, we want it to be higher, obviously, but it may not be, and she may have no signs or symptoms whatsoever of looking anemic. She may have adapted to this. Now, of course, if she is symptomatic, she's going to have tachycardia. She's going to be short of breath. She may have weakness, and so if those present with lower hemoglobin hematocrit, then obviously we're going to intervene. But just because she's a couple numbers low does not necessarily mean she is terribly anemic. It just means we need to find out what's going on and then keep a closer eye on her because she may be fine with that. So it's very individualized. Don't just look at numbers, as I have told you many times in the past. Obviously, folic acid deficiency is not a good thing because we know it increases the risk for neurotube defects, so they should be on folic acid right away. Even before they're pregnant, they should probably be on that. Pardon me. Give me a sip of water. Okay. Sickle cell disease. It's an autosomal recessive genetic disorder. Causes anemia because of abnormal hemoglobin, not necessarily of It doesn't carry oxygen, obviously, because it's malformed and misshapen, and it results in distortion and destruction of erythrocytes. So the erythrocytes actually take on what it looks like a sickle shape. And if you don't know what a sickle shape is, look it up on Google. All right, pretty simple. It's worsened. This disease can be worsened by the changes of pregnancy. And so we want to prevent sickle cell crisis, which is excruciatingly painful and dangerous. And you'll learn more about this in future classes. And while I'm thinking of this, there are certain immune diseases like lupus, rheumatoid arthritis, and so forth that sometimes feel better during pregnancy, or some can make it worse. So again, it's very individualized with those. So I just wanted to throw that out there. Seizure disorders. This is a woman who has an underlying seizure disorder, not necessarily related to eclampsia. So epilepsy, having seizures is the most common form of it. The management of epilepsy is unfortunately complicated by some of those drugs that are teratogenic. And so sometimes it's, the woman, the physician, have to sit down together and go through whatever medications are available and decide which one is the best for her. We don't want her to have a seizure by any stretch of the imagination, but we also know that some of these drugs are very teratogenic, so it's a very, very slippery slope sometimes. And so we have to take into consideration all these things, and then the woman and her physician should decide what's going on and what they need to do. And there's necessarily no cookie cutter recipe for these things. It's very individualized. Infections during pregnancy can be very deadly, as we know. CMV, rubella, chickenpox, herpes, pyrovirus, hepatitis B, all of those are very dangerous in pregnancy. We do not want women to get exposed to these. In good infection control practices, if you're sick, stay home. Hepatitis B, there is a vaccine for that we take before pregnancy, not during, because we cannot give a rubella MMR during pregnancy. It's a live vaccine. So a lot of these we cannot necessarily do anything about while they're pregnant, except just help them through that and watch the fetus. They can be detrimental to the fetus. So again, we want to prevent them if at all possible. Pardon me again. So the HIV virus, of course, we know it causes your immune system to fail, and you are very, very susceptible to a lot of infections. So we see here that there is treatment available, and there's antiviral medicines that can substantially reduce infection of the fetus. And if HIV is present, then this medicine should be started on the newborn 6 to 12 hours after birth. I don't know what's the matter with me. Remember that there are oftentimes to treat HIV. That doesn't mean you have AIDS, but you have the HIV infection. So in order to prevent you from converting over to AIDS, we give you the antiretroviral medicines. And so remember, there's many of them. There's more than people usually take more than one, and so they're expensive. They have to be taken very, very, very consistently. And so lots of times this woman may have to come in every 2 weeks for monitoring and so forth. So it's not an easy thing to treat, but it is treatable. We're having some success with that. This is from your book, the recommendations for prevention of perinatal human immunovirus deficiency virus infection of the infant. And you see there the recommendations they have for pregnancy, for during labor, for the newborn, and a cesarean section at 38 weeks before the onset of labor and rupture membranes is usual to reduce maternal transmission of human HIV to the fetus. Okay, HIV infected mothers are advised not to breastfeed. Okay, so they cannot. That's one of the contraindications to breastfeeding. Excuse me. And then, of course, we have non-viral infections. Toxoplasmosis can be transmitted by raw meat or infected cat feces. Group B strep is the leading cause of life-threatening, it should say not life-treating, life-threatening perinatal infections. And so that's why we check the Group B status of every pregnant woman. If we find out she's Group B positive, she's going to get 3 rounds of antibiotics, preferably before she delivers. And of course, tuberculosis can occur, although in this area, the incidence is not as high as other areas of the country. There's a lot of tuberculosis in New Mexico, Texas, Arizona, in particular because of the open border, and everybody's coming from there bringing who knows what, but especially tuberculosis because it's very prevalent in those countries. So we have to be on the alert for that as well. And unfortunately, the medicines given for tuberculosis are very, very harmful to the fetus, and so it may result in a lost pregnancy.